Sure. Thank you, Zenia. So, I'd like to introduce myself. I'm Aniruddha Mundhada. I'm working on research in lymphoma. Previously, I was with Dr. Vega in molecular diagnostic lab as well. And I would like to present a topic which would be very useful for hematopathology as well as in molecular coming forward. So this is the topic, beyond the tissue, liquid biopsy in lymphoma diagnosis. This would be the agenda. I will start off with the introduction, introducing liquid biopsy and then circulating tumor DNA. Then I'll talk about tumor-informed versus tumor-agnostic testing, coming to the kinetics of circulating tumor DNA, going on to the coverage and depth, the haploid gene and fragment length of circulating DNA. Then somewhat what tumor DNA testing means in clinical settings, also in cancer screening, then in risk assessment, and then in mutational profiling and treatment selections. Lastly, I would end with some closing thoughts and open for questions then. Coming to the introduction, so liquid biopsy is testing of any liquids in the body, which would be blood or urine or CSF or bile. Basically, we are testing for circulating free DNA or nucleic acid, which could be RNA as well as DNA, but most of the results are DNA, right? This was first conceptualized by Mandel in 1948, and later it was shown to be present by Stone and co-workers 50 years or almost 50 years back. So this is a general schema showing cells, tumor cells, in this case lymphoma cells, showing active secretion of this circulating tumor DNA, which would be through exosomes or even through exocytosis, leading to the presence of circulating tumor DNA in the fluids. So the timeline, going back to the history, there was detection of circulating tumor DNA quite a long time back, but Morris Strawn was the first to show that, and later on he became a part of consulting for Grail as well, which was the first company to introduce a circulating tumor DNA mark test, which was FDA approved in the market. Actually, ctDNA based testing has actually exploded in the last 75 years, in the last 10 years, leading up to many more companies which are offering circulating tumor DNA analysis as a standalone test for different diseases. First of all, the very famous which was there was 2016, which FDA approved, was epiprocolon for colon screening assay, but the sensitivity was almost 60% and not that great. And that was a major drawback for this test. But later on, every year, FDA has one or two tests for each, for one of the cancers. The major ones right now are Foundation 1 and Garden 360, which target liquid biopsy for multiple cancers. So what are the potential applications for such an assay? It could be for early detection and screening, which is the majority of the tests which are used right now. It could be used for prognosis or evaluation or personalized adjuvant therapy for the patient, detection of the residual disease and molecular relapse, treatment selection and monitoring of the patient to that treatment, and monitoring a clonal evolution of and progression of cancer and therapy response in such settings. This assay aids treatment decision in early and late stage cancers. So in early stage cancers, it can help to figure out the origin of the cancer from tissue, and should be confirmed by radiology, which is usually the standard of testing for confirmation for such cancers, assess the for neoadjuvant therapy, and see for any treatment-related changes or how the patient is responding to such therapy. If in such a setting, if the assay is positive, consider other treatments or continue with the same treatment. And if it is negative, then consider the treatment de-escalation, which means that this treatment might be working. In advanced disease, such a assay would be useful to accelerate or get the lead time in detecting a relapse or detecting a failed approach to the treatment. In such cases, we can initiate a targeted therapy, which would be for that cancer, or we can use a tissue biopsy to confirm the treatment failure or resistance to such treatments. Major use of such assay is to monitor serial plasma collections at time points during the therapy. And during those time points, consider it de-escalation or assess for resistance mechanisms during these treatment. So coming to two major concepts, which is circulating free DNA versus circulating tumor DNA. Blood contains cell-free DNA, which is from both the healthy and the tumor tissue, and that is almost 75 to 100 nanograms per ml, which is quite a lot. But in tumor cases, it is tumor-derived DNA, which is released during apoptosis or necrosis or any kind of cell damage from the tumor, and this is known as shredding, DNA shredding by the tumor. This ranges from less than 0.1% to over 10% of total cell-free DNA, depending on the type of cancer and tumor burden. In gliomas or CNS cancers, it is even less so because of blood-brain barrier, which the tumor cells are not able to cross into. Coming to the right-hand side, this is a diagram which shows that it is the circulating tumor DNA is basically finding a needle in a haystack. It constitutes less than 0.01% sometimes, or most of the times, in quite a lot in the usual blood which is extracted out. So 5 ml of plasma will contain less than 0.1% of total cell-free DNA, and even then the circulating tumor DNA will constitute a short fraction of cell-free DNA. On the right-hand side, and in the second diagram, the histone modification, the histone proteins are shown, and it constitutes 180 to 200 base pair, and cell-free DNA are usually centered around 166 base pair, which approximates the length of the DNA wrapped around the nucleosome. So it suggests that the cell-free DNA has a correlation with the histone, or it is in close approximation with histone proteins, and that is getting shed out. Coming to features of circulating tumor DNA. So it is the usual half-life is 16 minutes, but it has been described as less up till 2 hours as well. Is likely complex with cellular or non-cellular components. So it can bind to cell membrane or any other proteins or even the apoptotic bodies or nucleosome complexes. The size ranges from 500 base pair to more than 30 kb, but there are recent reports which suggest that these are very small fragments. As well as the technology evolves, it can detect more short fragments of circulating tumor DNA as well. The size distribution in the same sample, it has not been studied, but it has been studied in different disease conditions. And it has been shown to be different in different cancers. In solid tumors, it is different as compared to lymphomas. And diagnostic value for this fragment length analysis is still controversial, and it has not been shown to be useful right now. On the left-hand side, it is a schema of how the circulating tumor DNA has its features. So there are circulating tumor cells, and there are epigenetic modifications or many mutations, so point mutations, translocations, indels, chromosomal abnormalities, which can which can characterize ctDNA. And this can all be studied by sequencing or ultra deep sequencing for characterization of such changes. Coming to lymphoma management, so there are pre-analytical features which will help in preservation of ctDNA. So usually in follicular lymphoma, it is quite cohesive lymphoma, as that it does not shed such DNA much. But in PMBCL or DLBCL, it is much more because it is not as cohesive as a follicular lymphoma. And this correlates with tumor stage as well. In advanced stages, the DNA is much more as compared to earlier stages. At least 10 ml of blood on average has been studied in many of the studies, and that is required for getting a sufficient number of DNA molecules to be detectable by the sequencing. Plasma isolation, the timing also is important. Within 6 hours of processing is advised, but using Streck tubes which have stabilizing agent up to 7 days at room temperature, it can be stored. Confounding factors are germline variants or chip, and this may confound results. But as long as targeted sequencing is done, these errors can be removed. And paired sequencing relates to much more specific results as compared to single-end sequencing. So coming to liquid biopsies and the applications during pre and after treatment. Pre-treatment, it is useful for diagnosis, genotyping, and prognosis. And this can aid in the cell of origin classification and DLBCL, for example. It can also help in disease screening, early diagnosis, and getting the lead time for early diagnosis of lymphoma. During treatment, it will help the clinician to aid what target it is sensitive for. It is a screening tool for immunotherapy targets, and it is an ideal carrier for drugs or gene transfer. After treatment, majority of ctDNA can be used for MRD assessment, and that can aid in earlier MRD detection as compared to radio imaging or rebiopsy. So there are many studies which have been published in lymphoma management. Many are of DLBCL, but there are few studies which focus on Hodgkin's as well and mantle cell as well. And this is a chart which shows the many studies which have studied ctDNA as for DLBCL per se. So this was the section about lymphoma management and specifically ctDNA. Coming to concept of tumor-informed versus tumor-agnostic approach in circulating tumor DNA. So tumor-informed is using a patient tumor-specific mutations which are already known from a previous biopsy and testing that during a suspicion for relapse. And this becomes a personalized or custom assay for such a disease, and this helps in MRD detection for that disease. As compared to a tumor agnostic approach, there is no prior knowledge of the tumor mutational profile. Here we have only a blood sample as well as only a blood sample or a bone marrow sample to detect any mutation. And this would be a broader testing as compared to a tumor-informed approach. And this is useful for non-invasive genotyping or exploratory analysis for such patients. On the bottom shows a generic NGS panel which shows many mutations which can be targeted as long as the library prep is done, and same mutations can be analyzed for all the patients. So this becomes a off-the-shelf assay as compared to a custom assay in tumor-informed approach. This is a cartoon which shows a tumor-informed approach where the previous biopsy or a previous sample is available of the patient and a personalized assay is developed as compared to a tumor-uninformed approach, which is off the shelf and can be used for multiple diseases. So these differ in their technical consideration, and we will come to that later. Coming to coverage recommendations, so there are a few terms which are defined in ctDNA analysis, and that is the breadth or the depth of sequencing. The breadth is extension of the whole read sequence for as compared to the reference genome, and in the depth we can see the multiple reads which are corresponding to the reference genome, and in this case on the right hand side it would be 6x depth as compared to the left hand side, which is the 3x depth. This is usually calculated by a Lander-Waterman equation, which goes into the calculation of such coverage. And this would be important in the sequencing methods which are employed in such analysis. So we can see, for example, in whole genome sequencing, it is usually 30x to 50x for human WGS. In whole exome, it can go up to 100x. In RNA, it is usually millions of reads which are counted as compared to the depth. And in ChIP-seq and ATAC-seq, it is usually 100x. These are the other use cases where the depth can be about 100x, but in circulating tumor DNA, it is much higher because it is basically finding a very small particle, a fragmented DNA in a much larger normal sample. So that goes up to 1000x, mostly more than 1000x. In references, in many studies, it has been used 3000x or 5000x as well. So this is how a readout looks, and in short reads, which is Illumina and many of the other technologies which are used, there are usually some coverage gap in short read whole genome sequences, and that affects the results, and that there could be some mutations which are missed when the reads do not overlap or you do not have a complete readout. Here, I long read sequencing assay would be much useful as it can lead to capture of those mutations which are not which are missed by the short reads, as well as you can use a shorter depth to get a much more readout which would be much more complete. And this is what is being employed by a few of the companies like Nanopore and PacBio. So this could be one solution in order to get a much more complete readout as compared to short read sequencing, for which we need to have at least 1000x depth to get the mutations. Coming to the kinetics, so how do we measure circulating tumor DNA? So this is through circulating tumor DNA clearance, where at a times at a snapshot in time after the therapy, usually in the third cycle of treatment, we measure circulating tumor DNA and the change from the baseline, which was at the start of therapy or before therapy. And we measure how much nanograms per ml of ctDNA is present. And as long as it is reducing, it means that the therapy is working. In delta variant allele frequency, there is a mean change in VAFs, and this is not as quite as useful as a clearance, because even a 0.5% from 1% to 0.5% of change of VAF will lead to 50% drop or 100% drop, which might not be suggestive of the tumor of the MRD assay being positive or the tumor getting removed from the body. In molecular response, there is a ratio of on-treatment VF to pre-treatment VF, and this can also be studied where the ratio defines the treatment response. So some other features, the ctDNA is highly fragmented in that there are multiple mutations which leads to fragment of the template, and this constitutes less than 0.05 or 0.01% of the total cell-free DNA. For this case scenario, we need a much larger blood sample to test for ctDNA as compared to the usual blood sample for any other assay, so that we get enough copy numbers of such ctDNA to test for it using the sequencing technologies available here. There are three different approaches to test for these ctDNA, and we will focus on those later on. But one of them is targeted approach, and these are the different techniques we can use. Few of them being qPCR and ddPCR, which are quite sensitive in detecting 0.01% of ctDNA. Coming to another concept of how to measure ctDNA, we can say that it is haploid genome equivalent per ml. So in human genome is approximately 3.3 picogram per ml. And if we are calculating a 10 picogram per ml ctDNA in a blood sample, it would be 10,000 picogram, which is present in that 10 ml. This divided by 3.3 picogram results in almost 3,000 haploid genome. And this would be the final concentration, which is usually said to be present in a blood sample for ctDNA. So there are if there are multiple mutations in ctDNA, it will lead to much larger variant allele frequency, and that would be easier to capture by the existing sequencing technologies. But usually the ctDNA concentration and the volume of plasma is limited to 5 ml, for which we have a limited quantity of ctDNA, and the assay should be sensitive enough to detect a variant allele frequency of 0.1 or 0.01% to detect such mutations. And this table shows in a variant allele frequency of 0.01%, you need at least 33 nanograms of circulating tumor DNA to be present in a 5 ml volume of plasma. So that becomes a very challenging scenario in which the assay has to be sensitive enough to get to that concentration. Coming to detection of ctDNA using these three, I'll skip on this. I'll say this in short. So one is the targeted single locus or multiplex, which focuses on known mutations in a tumor profile. And this can have a high analytical sensitivity going up to 0.001% using ddPCR as well. So second is targeted sequencing, which is multi-loci sequencing using amplicon or hybrid capture based. And this can be used for multi-mutation profiling or monitoring the resistant or treatment response in such patients. In genome-wide coverage, it includes a whole genome sequencing platform. It detects all structural variants, but may miss out on some very small point mutations because it is not much sensitive, because the depth is limited by the breadth of the sequencing which is done. Coming to another schema which shows the fragment length and how it affects the readout of ctDNA. So usually the fragment is wrapped around a histone protein, which leads to a mononucleosome. It can club together with two and lead to a dinucleosome or even a trinucleosome, and that detects how much of the fragment length is involved. So 167 base pair is what a mononucleosome fragment will measure. Double of that will be a 344 base pair fragment, which is a dinucleosome, and that is much more rarer as compared to a mononucleosome. And this is what is detected uh, when such an assay is tested for. So ctDNA can overlap with circulating cell-free DNA, and this overlap can be uh, quite narrow. And if we can detect this part of the curve, we can actually narrow or make the assay more sensitive in detecting a ctDNA and leaving out all the circulating free DNA, which is the normal part. And that can make the assay more sensitive for ctDNA. The nuclear material preservative, which is added to the Streck tubes, which we use at molecular diagnostic lab, is also very important. In that, even the temperature changes, or even up to 7 days, we can store the sample as compared to a usual EDTA sample, where there might be damage to the already fragmented ctDNA, and that can lead to the assay being negative for relapse. There are other detection methods which compare um, as compared to ctDNA, but the most which comes close to sequencing would be ddPCR, which has a detection limit of 0.01%. It is faster, but it can only detect known mutations that are already present in the uh, previous sample. So this was much about introduction and the technicalities and kinetics and a few concepts about haploid genome equivalent in ctDNA. Coming to the clinical scenario, and first we'll start off with cancer screening. Currently recommended screening practices are by USPSTF, which recommends a population-based screening for lung cancers as well as other cancers. But it has to be um, but these screening tests are not very well available, or they cost too much, or they are not very sensitive. Hence, they are not very good, or in the sense that it can detect a cancer with a lead time which can help to start treatment for such cancers. So the adherence to these using these screening methodologies is currently limited, and ctDNA does not have a role right now um, in screening for such cancers. There are tests which have come up, especially Guardant and Foundation One, which have introduced a multi-cancer early detection testing scenarios where there is a shedding of ctDNA, and MCED test can detect by sequencing and bioinformatic approaches and predict the cell of origin of such cancers. And this has shown promise in that. This can detect a cancer much earlier than the traditional assays which are there in the market. So the first company which actually went ahead and introduced this in markets was Grail, and Maurice Strawn, which I showed as the pioneer of ctDNA, was actually consultant to Grail in the final years of his life. And this is how it has shown to detect the DNA in early detection for multiple cancer in in the plasma sample. And this was a study by Grail, which they published about CCGM, which is a circulating cell-free genome atlas, and it identified a genome-wide methylation patterns which which were much greater than whole genome sequencing or even cytogenetics for that matter. But the many problems which such tests face is that ctDNA simply does not have that much of a volume in the blood to be sensitive enough for these tests to work. So we are looking at the third scenario where even a 6 millimeter of tumor will have only a 0.001% of ctDNA, and that will be actually far less than one haploid genome equivalent, and this is unlikely to get a positive result in these tests. Potential impact is basically we are trying to get a lead time in before all the radiotherapy. So even at day 10 or day 30 after treatment, we can start looking at a relapse or detect a relapse, which in current scenario is by imaging, and that needs a much more um, mass to become positive as compared to ctDNA or liquid biopsy. Coming to risk assessment and prognosis. So in solid tumor MRD, it has been shown that it affects the clinical decision, and this can be used in lung cancer, breast cancer, colorectal or GI cancers. In lymphoma or in MRD settings, we are talking about the sampling and getting the lead time for earlier diagnosis. So after treatment, usually if the ctDNA level falls, it correlates with a better prognosis and that the tumor is not being shed from the tumor cells, and that would correlate with the tumor size shrinking as well. In ctDNA testing and mutational profiling and treatment selection, so it has a role in getting uh, in further classification of the tumors as compared to biopsy, and this can help in um, getting a much more personalized therapy for such tumors. In this case, we are talking about the lung cancer, where multiple ctDNA assays have been shown to be effective in defining the treatment selection. This was a white paper from Friends of Cancer Research in Philadelphia last week, and um, they've laid out a framework for making ctDNA and liquid biopsy much more prevalent and mainstream. And this was the critical recommendation they suggested of collecting a baseline ctDNA measurement before treatment and as compared to after treatment, usually on cycle and day one or third cycle of treatment. Ideally, we can collect ctDNA for 4 treatment cycles and 1 and 6 months post-treatment. And this would be the best ideal scenario for such assays. The assay should be sensitive enough to detect at least 70% of patients at baseline and report the data in an aligned approach so that it could be used for treatment-related decisions and management guidelines. Coming to industry assays which are out there, the most famous is Foundation 1 liquid assay. The oldest is Grail, which was the first to launch their liquid biopsy assay. Natera or Signatera, which has their assay in the market, and Garden 360 also is one of the players in the market. So coming to the closing thoughts and the future directions. So I'm just going through all these presentations and papers while working on the talk. I was thinking, can E-cadherin predict or correlate with the amount of ctDNA being shed in plasma for lymphoma? And can a heterogeneous tumor like a mixed cellularity Hodgkin or AITL have more ctDNA because there is decreased cohesiveness as compared to a more homogeneous lymphomas like a follicular lymphoma, which has been shown to have a less ctDNA in the plasma as compared to DLBCL. So these were some of the closing thoughts. These are my references for this talk. And I would be happy to take any questions. Thank you.
Very nice talk. I really enjoyed the everything you talk about, and thank you for opening this discussion. We need to have these discussions because these are the new technologies are coming, and we need to know them and know their pitfalls. So my question is like, the liquid biopsy has three potential applications. First is it can be used for screening, like cancer screening. There are some publication about that. They even claim that they might be able to screen for 42 different cancers. The
Yes.
second application is for diagnosis, like, like to confirm the diagnosis. And the third application is for treatment. And then, how you like when you treat, like we use it for in lung here, even in our lab, that we use it for like a follow-up and treatment efficiency and relapse, basically for monitoring. So in the lymphoma work and lymphoma world, what do you think, which step we can use it? Is it for diagnosis, for screening, or for monitoring the disease relapse? And like if you saw any publication or data about that. Thank you.
Sure. Thank you, Iman. So I think in lymphoma, um, the MCD, the multi-cancer early detection test, can incorporate a wide number of mutations in the panel, and that can detect a wide number of um, lymphomas. And also in the prognostication or the MRD assays where such a test would be quite sensitive. So liquid biopsy, I think, will help in multi-cancer early detection during the treatment and after the treatment to monitor relapse. And that has been shown in few of the papers. I think I shared one of them with you regarding liquid biopsy in lymphoma, where it has been shown to be useful in relapse. One important point to note here is we should be careful about CHIP, which is clonal hematopoiesis of indeterminate potential, and that can confound the results of such assays. And there are techniques and even bioinformatic approaches to reduce that. We can get rid of the germline mutations and be concentrated only for the actionable mutations or the targetable mutations. So yes.
Thank you.
Thank you, Emma.
Annie, I have a question, and maybe I
So,
don't know.
Kaving.
Hi. Then you mentioned, and it is believed that the circulating free DNA is shredding from the tumor. Therefore, in situations of chemo, or the neoplastic cells die, there is going to be more shredding and to have more levels of detection of tumor-related
Yeah.
free. My question is, do you envision or do you think that there is really another function, biological function by the tumor to send this DNA, and it's related with maybe the exosomes? No, the exosomes are better studied, right? But could be anything else there that we are missing here, and it's not just a passive shredding, just the DNA?
So, yes, Dr. Vega, I think there might be a much more biology involved in such a circulating tumor DNA, which is being shed. And it is usually being, we say shed, but it can be actively secreted using exosome as well. The problem is after capturing or after starting treatment, we actually do not know the rate of the shed. So even if we take the sample at, let's say, day 7 or day 14, the circulating tumor DNA only has a half-life of, let's say, 2 hours. So we can miss it all completely altogether, and it can not be present in the blood when we take that sample. Regarding the biology, it can point to we can take an example of DLBCL, which is a B cell lymphoma. So even if the B cells are getting destroyed, the T cells or any other cells of the immune system, that feedback loop is destroyed. And in that sense, there would be increase of the T cells as well, or decrease of the B cells, and that biology is still not studied very much, and it needs to be studied more. But you have got a point there that the cellular crosstalk, when such a circulating tumor DNA happens, or when the DNA is being shed out, that has not been defined yet.
Thank you.
Thank you, Dr. Vega.
I guess if there's no more questions, we'll steal back a little bit of time from the day. But Ani, that was a fantastic talk. I learned so much, and the perspective that you gave was, I don't know, completely excellent. Thank you so much for your time.
Thank you, Xenia. Thank you for hosting me. All right.
I hope everyone has a good day. Bye.